Robin. I would like to know, how did you start with Faricimab? Did you inject everybody? Or?
That's a really good question. So I think, like anybody who starts with new anti-VEGFs, is you really want to get a feel for it. We have the RCT data, but realistically, when you get the new anti-VEGF, is you try it on those patients who are difficult to treat. So we call those high frequency users, frequent flyers, aggressive CNVs. So we had a cohort of patients who were having very regular injections. So they were on 4 weekly injections, and if you tried to extend them out, then you would get fluid.
Recurrence, yeah.
Exactly, and we all have those patients. So we took that as the first cohort, and we reported that at ARVO this year. So we have just over 100 patients who, on average, had the last 3 injections 4.1 weeks apart. So really high frequency users, and in the previous year they'd had 10 injections. On average, they had had around 33 injections and over 3 years of treatment. So again, chronic users. And what we found is when we switched these patients, the proportion of dry retina went from around 18%. And remember, that's an 18% on 4 weekly were dry.
Yeah.
So there were 82% who weren't, and that increased to 56% after 1, and then went up to 67% after 3 injections of Faricimab, who were completely dry. So,
but this was the loading dose, meaning every month.
Well, these patients were on monthly anyway.
Okay. Yeah.
So they were used to getting monthly, and they knew if they went anything beyond 4 weeks, they would have fluid recurrence, or they still had fluid on 4 weeks. So we would load those. And what we found, actually, if you went dry quickly, the concept of then extending by 4 weeks would seem obvious. So if you went dry after 1 injection, dry again, extend by 4 weeks, we found that that's probably not the best idea. So in the frequent flyers, we started to extend only by 2 weeks.
Yeah.
And on average now, these patients are out at just over 7 weeks at the end of 1 year. So previously being on 4 weeks, now over 7 weeks on average. And some have got to 12 weeks and beyond. And dry. Yeah. So really good. So that's where we started. Once you see somebody who's a high frequent flyer go dry, you then say, okay, this is a good drug. Let's use it on our treatment naives. And again, we reported our treatment naives at the meeting here. We had 120 patients. And again, really good outcomes. So a lot of them go dry very quickly, and the ability to extend was significant. So again, when you start, you think, do you know what, maybe we should be extending by 2 weeks, but if you're dry after 1 injection, you're comfortable extending by 4 weeks. Exactly, you feel comfortable. And so by the end of the first year, the median injection interval was 12 weeks.
Wow.
Which is a deal breaker. So then we started to, a lot of our patients, we were switching a lot of our patients who were anything under 8 weeks, so not just our frequent flyers, but anyone who was under 8 weeks, we started to switch. If you're doing well on 2 milligrams at 8 weeks, 10 weeks, 12 weeks, fine, continue with the 2 milligrams. But if you're struggling to extend beyond, to 8 weeks and beyond, it seems sensible to switch. And we started all our new patients on Faricimab, because it seemed that we were getting out to 12 weeks by the end of year 1. And then we examined to see how that was affecting our clinic capacity, which is a big deal in the NHS. So we found that rather than this big incline that you can see with the current drugs, you know, we're treating more and more patients, we're starting to flatline and maybe even starting to drop down a little bit, particularly with our diabetics now as well. So we're actually probably around flatlining, which is great, which is really, really good. Our patients love it because they're coming less frequently. The other thing to comment on is how safe is the drug.
Yes, exactly.
So again, probably because of Beovu, we were concerned about inflammation. We saw minimal inflammation in the RCT. We still see our patients on the slit lamp at Moorfileds, probably as a hangover from the Beovu days, but we still see it. And so we're fairly comfortable with our accurate reporting of our inflammation. And it's around 0.2% in the real world. So we looked at over 10,000 injections, 0.2%. No significant no vasculitis, but no significant inflammation, and all patients were comfortably treated.
Truki said 0.1, and Ferretina is roughly 0.12.
Yes.
So
yes.
yeah.
Yeah, so it's around the same.
Or
and
point something.
Yeah, 0 point something. And I think anything below 1%, I think
Yeah.
we're comfortable with. But I think, 1 in 0.2, so 1 in 500 or something, I think that's reasonable. And again, these were not only patients who were symptomatic, these were asymptomatic. When you see cells on the slit lamp, we recorded those. So we're probably seeing slightly higher, or reporting slightly higher than the truckee or
And there's
the
no
far retina.
consequences of those inflammation?
To date, no.
Okay, nice, great. So you started with difficult patients, then you're moving to easier and easier. NHS is comfortable with that?
A lot of the NHS is funding it.
Yeah.
The difficulty is making sure that it is cost effective.
Yes.
For the funders. We have an issue, you could describe it as an issue with the biosimilars, or an opportunity with the biosimilars, because these are a lot cheaper. And there are a lot of units which are using the biosimilars. Now, the problem with the biosimilars is you're not getting to the same treatment extension. And we have a group who are just using the Ongavia, which is the biosimilar of choice, the first one that came to the NHS. And their AMD cohort median interval, end of year 1, is 6 weeks.
Yeah, so it's cheaper, but it's more often. So
it's more frequent.
Finally.
And then you have to work out the cost effectivity
Yeah.
of more frequent injections versus drug price. And that's a piece of work that we're doing at the moment.
Yeah, but you have to drive the patients and,
Yes. And also, if you've got something that isn't drying so fast, every time you switch, you're essentially saying you're failing.
Yeah.
We'd like to fail less, particularly in AMD.
Okay.